that you can indeed see my screen.
We're all good.
Perfect. Okay, so this evening we are going to be talking about peripartum cardiomyopathy. As Sam has mentioned, it's obviously quite a rare condition, but one that has significant effects on morbidity and mortality for our pregnant patients, and therefore quite an important topic. So I think no talk on a cardiac topic in pregnancy would be complete without including some of the cardiovascular adaptations that occur during pregnancy. And we're just going to look at them very briefly. So the first would be the hematological changes. So we have this multifactorial stimulation of fluid retention and erythropoiesis in pregnancy, which results in a 50% increase in plasma volume and a 30% increase in cell mass, creating a relative physiologic anemia and an increased blood volume. If we look at cardiac output changes, cardiac output actually increases 50% in normal pregnancy. And this is predominantly due to an increased stroke volume in the first and the second trimester. And then there's the added contribution of an increased pulse rate in the third trimester. We also know that during labor and delivery, cardiac output really skyrockets and increases by a further 40 to 50%. And then lastly, positional changes have hemodynamic effects, which can be quite significant on pregnant women. The compression of the inferior vena cava by the gravid uterus in the supine position may actually cause hypotension and in some severe cases, even syncope. And if you turn the patient into the left lateral decubitus, you can actually relieve this compression and restore the venous return. So what I'm trying to illustrate here is that in order for us to be able to undergo these these physiological changes in pregnancy, we really need a heart that's functioning really well. So the ESC actually came up with this working group on peripartum cardiomyopathy, and they published this definition in 2010. And so the definition that we use in South Africa is the development of heart failure towards the end of pregnancy or within 5 months of delivery, in the absence of another identifiable cause of heart failure, with left ventricular systolic dysfunction with a left ventricular ejection fraction of less than 45%, with or without left ventricular dilatation. So you might be thinking, well, this seems quite sort of vague. What is the end of pregnancy? And actually the ESC has been, they have decided to be vague about this definition because they wanted to make sure that we didn't exclude patients just because they didn't present within a specific gestational age cutoff. If we think about the epidemiology and the incidence, there's actually a large prospective international registry of about 411 women from 43 countries that demonstrates that peripartum cardiomyopathy occurs globally, affecting women from all ethnicities on all continents. However, incidence rates vary quite widely depending on geographical location. So you can see, for example, that Sweden has a very low incidence, where in, for example, South Africa, Haiti, or Nigeria, the incidence is much higher. And so there might be genetic predisposition, which actually contributes to this geographical variability. And the higher prevalence of peripartum cardiomyopathy in Haiti, for example. So Haiti, I had to actually look this up, is a small country in the Caribbean, which after the Europeans settled there was populated by African slaves. And so the fact that they have a very high prevalence there actually supports the notion that females in the African diaspora have a higher risk of developing peripartum cardiomyopathy. There also seem to be non-racial regional variations in peripartum cardiomyopathy, and this was demonstrated in a large study that reported differences in women from the Kanto region compared to other regions in Nigeria. What's also really important to note is that the incidence of peripartum cardiomyopathy is unfortunately increasing, and this may be due to improved diagnosis and recognition, but also might be due to an increase in risk factors. So an increase in maternal age, preeclampsia, nulliparity, multiple gestations, etc. So let's look a little bit at the pathophysiological mechanisms. And I'm going to take a second just here to speak about oxidative stress in pregnancy, because as obstetricians, this is not a concept that we think about often. So oxidative stress is caused by an imbalance between the production of reactive oxygen species and a biological system's capacity to detoxify those oxygen species or repair the resulting damage. the level of oxidative stress actually rises during pregnancy, and that's normal, and specifically rises late in pregnancy. And we think that the biological function of this rise is to actually increase the maternal defense against pathogens, which, because the immune system is compromised, and we have an increased risk, especially during the time during delivery. However, in normal pregnancies, this increased reactive oxygen species production is paralleled by an increase in antioxidant capacity. So this oxidative stress and antioxidant capacity is actually balanced. And this maintains a healthy third trimester and in the early peripartum period. The issue is when the antioxidant defense system is unbalanced, there's a shift towards oxidative stress. And this then predisposes the patient to peripartum cardiomyopathy. So if you look in the middle of the screen you'll see reactive oxygen species. And now we need to speak about prolactin. So we've all heard about prolactin's role in the development of peripartum cardiomyopathy. But really what happens is prolactin in its 23 kilodalton form, which is actually the long chain, has pro-angiogenic effects. But then under the influence of reactive oxygen species and cathepsin D, this is maybe another molecule that you've heard of, this 23 kilodalton, which is actually the good guy, gets converted to 16 kilodalton. And 16 kilodalton prolactin is actually called vasoinhibin, and it's got potent anti-angiogenic properties. The 16 kilodalton prolactin causes widespread endothelial dysfunction and destruction by causing endothelial cell cycle arrest, endothelial inflammation, and promotes the attachment of leukocytes to the endothelium. And although it doesn't directly actually affect the cardiomyocyte, it results in the formation of this microRNA 146A. Okay, and this can actually directly decrease the metabolic activity of the cardiomyocyte and impairs endothelial to cardiomyocyte communication. So you might be asking yourself, where does the placenta fit into all of this? So it's actually been observed that there's an association between preeclampsia and peripartum cardiomyopathy. And we all know that S-FLT has anti-angiogenic properties and that this molecule is upregulated in women who develop preeclampsia. This is usually accompanied by a decrease in VEGF. So VEGF, we know, has potent pro-angiogenic factors because S-FLT directly antagonizes VEGF. And this is how preeclampsia goes about. We know this really well. But this might also actually explain why peripartum cardiomyopathy develops, because we must think of peripartum cardiomyopathy as a disease of the endothelium, leading to loss of damage of the vasculature, and as a consequence, a functional insufficiency of the heart owing to impaired blood flow. So what are the risk factors? So if you look at these risk factors, you might realize that many of them are actually present in your patients who present with peripartum cardiomyopathy. I'll take an example of a woman who was admitted into our high care unit earlier in the year. So she was a 41-year-old, gravid of 5, para 4, who was unbooked. She informed us that she was smoking and that she was using TIC or methamphetamines. She was diagnosed with a twin pregnancy when she booked with late onset preeclampsia, and so she subsequently went on to develop peripartum cardiomyopathy. So if you look at these risk factors, you might actually be able to recognize them in many of your patients. If we look at the timing of onset in South Africa, the majority of our patients are diagnosed in the first 3 months postpartum, with the rest being diagnosed between 4 and 6 months postpartum. But this is sort of in contrast to what's happening in the rest of the world, where up to 25% of their patients are diagnosed antenatally. And this has me thinking, why are we not really seeing our patients in the antepartum period? Is this maybe just a failure of our healthcare system, or are there true geographical variations here in how patients present? The described mortality in the literature varies between 20 to 30%. And in South Africa, we're looking at a mortality rate of around 15%. So let's look in detail at the clinical presentation of peripartum cardiomyopathy. So the presentation can be quite variable, but it is similar to other forms of systolic heart failure due to cardiomyopathy. And most commonly, patients will actually complain of dyspnea, a cough, orthopnea, paroxysmal nocturnal dyspnea, pedal edema, and hemoptysis. And unfortunately, the initial diagnosis can be quite delayed because when patients present with these signs and symptoms late on pregnancy, we usually ascribe it to sort of normal symptoms in the latter part of pregnancy. And so this really should alert us to the fact that if a patient presents, telling us she's really tired or really short of breath, that we should look out for peripartum cardiomyopathy. Physical signs can include an increased JVP, of course, a displaced apical impulse, a third heart sound, and a murmur of mitral regurgitation. If we look at the ECG abnormalities can actually be found in up to 50% of these patients with peripartum cardiomyopathy, but a normal ECG does not exclude it. And ECG findings are really actually non-specific, so usually a sign of tachycardia and non-specific ST and T wave abnormalities, and in rare cases you might actually find that the patient has atrial fibrillation. A chest X-ray is not necessary to make the diagnosis of heart failure or peripartum cardiomyopathy, and unfortunately it does actually expose the patient to ionizing radiation. But if despite thorough physical examination you are still not completely sure if there's pulmonary edema, then definitely a chest radiograph is indicated. And then lastly, so we'll talk a little bit about natriuretic peptides in some of the next slides. And then lastly, the echocardiogram. So an echo should be performed in any patient who you are suspecting might have a peripartum cardiomyopathy. The echocardiogram generally reveals global reduction in left ventricular systolic function with an ejection fraction nearly always less than 45%. The left ventricle is frequently but not always dilated, and you might see signs of right heart failure and acute pulmonary hypertension. So if we think about mild peripartum cardiomyopathy, these patients usually present with subacute heart failure. They are hemodynamically stable. The ECG usually has no specific changes. The chest X-ray might reveal some evidence of pulmonary congestion, but may also be completely normal. Natriuretic peptides are mildly increased, and left ventricular ejection fraction is usually between 30 and 45%. If we look at moderate peripartum cardiomyopathy, so now the patient is definitely more ill, she presents an acute heart failure and may have hemodynamic instability with respiratory insufficiency. Once again, that ECG is quite nonspecific, but often a tachycardia is present. Chest X-ray shows signs of pulmonary congestion or pulmonary edema, and you might start to see an increased cardiothoracic ratio. Natriuretic peptides now are more increased, and left ventricular ejection fraction is usually between 20 and 35%. And then you get these patients who present with severe peripartum cardiomyopathy, and these patients come in with cardiogenic shock. They are hemodynamically unstable with severe respiratory insufficiency, and many of them will require intubation and ventilation. The ECG is once again non-specific, but in really severe cases, patients can present with atrial fibrillation or atrial flutter. They have pulmonary congestion with an increased cardiothoracic ratio, and in some cases may even have pleural effusions. Natriuretic peptides are significantly up, and the left ventricular ejection fraction is now less than 20%. If we think about the differential diagnosis of peripartum cardiomyopathy, because remember that the definition says that it's a diagnosis of exclusion, we are thinking about pre-existing cardiac disease like pre-existing cardiomyopathy, valvular disease, or undiagnosed congenital cardiac disease. Because metabolic disorders in maternal age are on a rise, we're seeing more diastolic heart failure secondary to hypertensive disease. Pulmonary embolus should always be high up on your list of differentials, and myocardial infarctions, although rare, can occur. So what is your diagnostic flow going to look like? How are you going to come to this diagnosis of peripartum cardiomyopathy? So you would obviously suspect it based on the patient's symptoms and the signs that you obtained from your physical examination, and you would rapidly progress to your workup. So ECG, chest X-ray, BNP, and echocardiography. If your natriuretic peptides are increased and your left ventricular ejection fraction is less than 45% in the absence of other causes, this is most likely acute peripartum cardiomyopathy. If natriuretic peptides are increased but your left ventricular ejection fraction is more than 45, you need to consider other cardiac and extracardiac origins of the symptoms. And we also need to remember that natriuretic peptides can be increased in normal pregnancy and are further increased in patients who have hypertensive disorders of pregnancy like preeclampsia and eclampsia. If natriuretic peptides are normal and left ventricular ejection fraction is more than 45%, you can feel quite comfortable that the patient's symptoms and signs are most likely not due to a cardiac cause, but you do need to look for other extra cardiac causes. So I wanted to just show you some pictures, and I think Taslim is going to show us even more, but this is an apical four-chamber view obtained in a patient with a peripartum cardiomyopathy. That's the picture on the left. And you can see here that there's dilatation of all four of the cardiac chambers, but specifically the left ventricle. So in the adult, a lot of us who are doing fetal medicine, we often look at fetuses' hearts, but in the adult, the left ventricle is slightly more dominant than the right ventricle. But here you can see that the left ventricle is much larger than the right ventricle. If you activate color flow, you see this blue jet, so blood is moving away from the probe over the mitral valve, and this actually signifies that there's significant mitral regurgitation. The picture on the right is very typical of pulmonary edema or interstitial edema. We see peribronchial cuffing, this perihilar haze, which is quite symmetrical on both sides. There might be upper lobe diversion. And then if you could see the cardiac border nicely, you could comment on increased cardiothoracic ratio. And here you can see small bilateral pericardial effusions. So how do we manage these patients? So the components of therapy would include heart failure, goal-directed medical therapy, hemodynamic support, multidisciplinary team planning of labor delivery and postpartum care. You'd like to institute chronic therapies that improve long-term outcomes. And of course, no discussion in obstetrics is complete without mentioning contraception and counseling for future pregnancies. So this little diagram actually shows you sort of the flow of a patient's management who presents with severe peripartum cardiomyopathy. So the initial management would include intubation and ventilation with positive airway pressure ventilation. You might consider using a ventricular assistive device. So Impella is just the brand name for the specific ventricular assistive device. You might use inotropic support and vasopressors like dobutamine and norepinephrine, and we'll discuss them in detail a little bit later. I recently learned of this inodilator called levosimendan, and this is specifically a drug that can be used in decompensated cardiac failure. You would use the diuretics and antifailure treatment during the course of your pregnancy, and then once she's discharged, she would continue on antifailure treatment. You would definitely anticoagulate the patient either therapeutically or prophylactically during her stay in the hospital and beyond. And then you might consider lactation suppression with bromocriptine, and we'll look at the details regarding that a little bit later. What I'm trying to stress here is that as an obstetrician, most likely, if your patient is at this point, you are in over your head and you need to involve a multidisciplinary team. So that might include an obstetrician and an MFM subspecialist, an intensivist, a cardiologist, a neonatologist, a neonatologist. And if your patient really isn't improving, you would need to involve the transplant team. These are some examples of management algorithms. So this is looking specifically at patients who have severe peripartum cardiomyopathy with cardiopulmonary distress. And here you really need to institute aggressive therapy, and your patient needs to be admitted to the ICU. Your initial therapies would include four main elements. So firstly, you want to optimize the preload, and depending on the clinical scenario, this will involve either the cautious administration of fluids, or if there's signs of clinical overload, the administration of IV diuretics, and this is actually the more common clinical scenario. At the same time, we need to target the optimization of oxygenation with a recommendation of maintaining saturation above 95%, especially if the fetus is still on board. Non-invasive ventilation is actually a really good option here, and we know that it decreases the need for mechanical ventilation and decreases mortality. You also need to restore hemodynamics to avoid irreversible organ damage, and here you might use inotropes and or vasopressors. But I do want to caution against the use of inotropes and vasopressors in the presence of decompensated cardiac failure, because we know that these agents actually increase the myocardial oxygen demand, which may further worsen the clinical picture. If decompensated cardiac failure occurs antenatally, you need to urgently deliver the baby. And in most cases, if the patient is this ill, she would require a cesarean section. So you would consider mechanical circulatory support, like we mentioned, the ventricular assisted device, but in some settings, this may even include ECMO. And then you want to assess your patient for recovery. So if she's not recovering at all and cardiac function is not recovering, you need to involve the transplant team urgently to see if you could put her on a transplant list for an urgent cardiac transplant. If she's recovering, then that's great, and you're going to start weaning her treatment. So hopefully your patient who's really ill will end up here, where she has peripartum cardiomyopathy without cardiopulmonary distress. And here we really look at patients who are antepartum and postpartum. So in the antepartum period, we institute heart failure therapy, and our options are quite limited in this antepartum period, but we can use hydralazine, IV nitrates, beta blockers if there's not acute decompensated cardiac failure, and diuretics, usually in an IV format. And then you would plan delivery and you would consider using an epidural anesthetic to maintain preload and afterload during labor and delivery. Once your patient is postpartum, you now need to institute heart failure therapy that has long-term effects on morbidity and mortality. And some of these drugs we don't often use as obstetricians, so I'll just briefly go through them. So ACE inhibitors, we all know, enalapril could be started at a low dose. Angiotensin receptor blockers, for example, valsartan is an option. Beta blockers here, initially IV and then weaned onto oral. And the drug that we most commonly use is actually carvedilol. The ARNIs, these are angiotensin receptor neprilysin inhibitors, newer drugs that have significant effects on mortality. The SLG2s, we know this in terms of diabetes treatment, but these can also be used in the treatment of heart failure. Aldosterone inhibitors, we know them very well, spironolactone, and then diuretics, and most commonly we use furosemide. You would then consider bromocriptine treatment, and the dose and the duration will depend on the severity of the patient's condition. And certainly you would consider anticoagulation, either prophylactic low molecular weight heparin or therapeutic anticoagulation, for example, if your patient has a left ventricular thrombus. So let's quickly recap just a little bit about bromocriptine and physiology with breastfeeding. So we know that prolactin is released from the anterior pituitary, and specifically the lactotrophs in the anterior pituitary. And this is under the influence of dopamine via negative feedback from the hypothalamus. So when dopamine levels are increased, there's actually decreased prolactin release from the lactotrophs in the anterior pituitary. So bromocriptine is a dopamine agonist. So it increases dopamine, it increases negative feedback. And by doing so, it decreases prolactin release from the anterior pituitary. And that's actually the mechanism that we're targeting. We want to prevent that conversion of 23 kilodaltons to the toxic 16 kilodalton form of prolactin. So the first studies on bromocriptine and peripartum cardiomyopathy were actually published, this research actually comes from South Africa, so we can feel very proud. The model was already demonstrated in mice models where they found that giving bromocriptine to mice with peripartum cardiomyopathy improved their outcomes. And so this was the first work done in humans, published in 2010 by Professor Sliwa and her team. So they looked at the evaluation of bromocriptine in the treatment of acute severe peripartum cardiomyopathy. This was a proof of concept pilot study, so very small numbers, 10 patients in each group. And they actually compared the standard heart failure treatment to the standard heart failure treatment with the addition of bromocriptine. They gave patients either 2.5 milligrams 12 hourly for 2 weeks, and then they gave them 2.5 milligrams daily for 6 weeks. And then the other group just received the standard of care, which would be standard heart failure treatment. And what they found after 6 months was quite interesting. So in the bromocriptine group, they had only one demise, where in the standard care group, 40%, so 4 of their patients demised. There were no patients with New York Heart 3 or 4 in the bromocriptine group, and almost all ejection fractions recovered to above 35 in the bromocriptine group. So they concluded that the addition of bromocriptine to standard heart failure therapy appeared to improve left ventricular ejection fraction and a composite clinical outcome in women, although they realized that there was a limitation, that their study numbers were really small. And they said that larger scale multi-center and blinded studies are in progress to test the strategy more robustly, but this is actually where the problem comes in. So this group from Germany, they published in 2018 in the European Heart Journal, and they were looking once again at bromocriptine for the treatment of peripartum cardiomyopathy. So they really wanted to do the randomized controlled trial that Professor Sliwa and them were referring to in their early study. But the ethics department actually said that based on the findings of that first study, where patients who received bromocriptine did so much better than the other group, it was actually unethical not to give women who had peripartum cardiomyopathy bromocriptine. So what they ended up doing is randomizing patients into two different groups. They had the bromocriptine for 1 week group, and then they had the bromocriptine for a total of 8 weeks. And they had about 32 patients in each arm, so slightly bigger numbers than the first studies. And what they found really wasn't a massive difference between the two groups. Their groups seemed to be quite equal. But they had this dilemma that they didn't really have a true control because they didn't have a group that didn't receive bromocriptine. So what they did is they looked at the data from this IPAC cohort. So the IPAC is actually a registry study from North America, and it describes the clinical outcomes of around 100 patients, and only one of those patients received bromocriptine. So this was a good opportunity for them to compare their bromocriptine cohort to the non-bromocriptine cohort of the IPAC study. And essentially, they looked at the patients who were worse off, so those with left ventricular ejection fractions of less than 30% from each study. And this is what they found. Patients who received bromocriptine tended to be much better off at the 6-month follow-up, with left ventricular ejection fractions improving remarkably in the bromocriptine group. And actually, none of the patients in the bromocriptine group died, where 15% of the patients in the IPAC study with an ejection fraction of less than 30% died. So they came up with this treatment regimen, and this is how they think patients who have peripartum cardiomyopathy should be managed. They call it the BORD scheme. That's just an easy mnemonic to remember. The B is for bromocriptine, the O is for oral heart failure drugs, A is for anticoagulation, R is for relaxants, and D is for diuretics. And they actually have quite a strict prescription of how they think bromocriptine should be administered based on the severity of which the patient presents with. Of course, we need to speak about counseling these patients and how we would manage them in the next pregnancy. So in patients who have partially or fully recovered left ventricular ejection fraction, so here we're speaking about patients who have an LVEF of more than 50%, you need to counsel them that there is still a substantial risk of relapse with subsequent pregnancy. The risk of heart failure or death here is less than 10% though, and usually there's a good fetal outcome. Where if you look at those patients who have poorly recovered left ventricular function with an ejection fraction of less than 50%, they have a high risk of relapse with subsequent pregnancy, risk of heart failure or death of more than 10%. They have an increased risk of premature delivery, and they also have an increased risk of fetal death. So the counseling here is really important. What you also need to take into account is the general maternal health factors, so patients who are less than 18 or more than 35 years, if there's poor maternal education or low socioeconomic status, if they have a long distance to appropriate care, so follow-up will be quite difficult, or if they've presented late, so after 20 weeks of gestation. The question is, how should you manage these patients? So if they've fully recovered or at least partially recovered, the pregnancy can continue, but some risks will remain. You would consider bromocriptine in the postpartum period, and you would definitely admit to the high care unit if they were to decompensate. Of course, all these patients need to be referred to an expert center with careful counseling of their risk, and you need to do close monitoring by a cardiac obstetric anesthetic team. They actually recommend monthly echocardiograms, and this isn't always feasible in our setting, but is a recommendation from the ESC. And they also say that we could monitor with pro-BNP in the pre and postpartum period. Obviously, that postpartum period is a very high-risk period, and so you'd have to watch your patient very carefully then, and you would definitely advise good contraceptive advice. I'm not going to go through the specific management again, but here, once again, they just suggest the BORD scheme of treatment. If we look at contraception, so there's no specific contraception that's recommended for patients with specifically peripartum cardiomyopathy, but if we look at the WHO MEC, We can see that copper devices is a MEC1, progesterone-only pills a MEC2, implants a MEC2, and even a gestural intrauterine systems also a MEC2. So we try to steer away from combined hormonal contraceptives and progesterone-only injectables. I think the message here really is just that you should provide safe, effective, and long-acting contraception. And that is all I have to say. Thank you for listening. I really appreciate it.
Thank you, Polly. That was absolutely brilliant. I love the fact that you went into the new insights and also delved into the very practical aspects. So we are going to actually move on. Our next speaker is Dr. Tasneem Hassim, and she's going to take us through an interesting case, which we are going to discuss. While she is loading her slide, I'm just going to encourage you to already start putting in your questions, either in the Q&A or in the chat section of the webinar, so that we can get through those questions, hopefully as many as we can in the time that we have left. So please do start typing that in. Tasneem, I'm going to hand over to you.
Hi, good evening, everyone. Samantha, please confirm that you can see my slides.
I can, thank you.
Okay. So when we decided to do this webinar, I was looking for a very interesting patient and I couldn't find someone that fits all the blocks. And the very next day, this patient came into our obstetric critical care unit. It's meant to be. So I'm going to be referring to as patient X from now. She is a 33-year-old gravid of 4 Paris 3. She's RVD negative. She had 2 previous term uncomplicated normal vaginal deliveries. And in 2016, her pregnancy was complicated by a peripartum cardiomyopathy. Her echo revealed a severely impaired left ventricular systolic dysfunction, also with severe pulmonary hypertension and severe mitral regurgitation. Subsequently, in 2017, she was followed up at the cardiology OPD with no recovery of her peripartum cardiomyopathy, and the routine cardiomyopathy screen to look for other causes was negative. In the same year, her clinical course was complicated by a cerebrovascular accident, where her echo revealed a thrombus on the apex of her left ventricle. She at this point had a left-sided hemiparesis, was started on therapeutic oral anticoagulation with full neurological recovery. Unfortunately, the patient was lost to follow-up from 2017 to 2019, but was seen in 2019 at the cardiology OPD, where she was noted to be severely symptomatic, and the consideration for her to be put on the cardiac transplant list was made if she is still symptomatic on optimal medical therapy. Her medical therapy was then optimized and she was on maximum doses of oral heart failure therapy as well as oral anticoagulant. Unfortunately, the patient was lost to follow up for another 5 years. So this is the echo that I have pre-pregnancy. So as you can see, her left ventricular end diastolic diameter is 6.4 centimeters with a dilated left ventricle and a severely impaired left ventricular systolic function of less than 20%. And all 4 chambers are dilated with mitral regurgitation and pulmonary hypertension. And as I said before, she had a 25 by 10 millimeter thrombus in the apex of her left ventricle. The patient was lost to follow-up. She had an unplanned but wanted pregnancy in the interim. So she booked early at 9 weeks gestational age, but omitted her previous cardiac history to the booking midwife at the maternity unit. She subsequently had 3 uneventful antenatal visits at the local facility, where her clinical parameters were documented to be normal with no symptoms of cardiac decompensation. As we expected, at 30 weeks and 6 days, she presented to our Tygerberg labor ward with acute onset shortness of breath, frontal headache, and worsening paroxysmal nocturnal dyspnea and orthopnea. On arrival, her GCS was 15 with brisk reflexes. She was put in the 45-degree head-up position. She was breathing at a respiratory rate of 38 cycles per minute and saturating well on face mask oxygen. She had an abdominothoracic breathing pattern together with accessory muscle use and bilateral crepitations on the lung basis, with no endpoints for mechanical circulatory support at this point. She was tachycardic with a heart rate of 110 beats per minute. She had acute severe hypertension with a raised JVP, a loud P2, as well as a displaced apex beat. And clinically, she was in cardiac failure. So we have a arterial blood gas that was done in our admission unit. And as you can see, her partial oxygen pressure is 8.6, and this is on room air. So the patient is hypoxic with saturating at 92% on room air. The chest X-ray is not the best X-ray, but as we can see, she has upper lobe diversion. And if you can imagine the bat wing sign, you'll be able to see it together with curly B lines, alveolar edema, and it is a bit difficult to see cardiomegaly on this chest X-ray. So her ECG basically showed a sinus tachycardia with a normal PR interval, a normal axis, no bundle branch block, and an enlarged left atrium with no features of right or left ventricular hypertrophy. But however, you can beats. So what is our differential with the previous peripartum cardiomyopathy was on maximum oral anti-failure treatment with no recovery cardiac failure, in pulmonary edema, but not in cardiogenic shock. We also may have early onset preeclampsia, either and or an overlap with the cardiomyopathy with severe features evidenced by acute severe hypertension, proteinuria, type 1 respiratory failure requiring respiratory support, together with clinical and radiological evidence to support acute pulmonary edema and likely with diastolic dysfunction. Her biochemistry was normal and there was no clinical maternal ascites. We must never forget to think about a pulmonary embolus, an acute viral pneumonia, for example, H1N1 of the COVID-19 virus, as well as pregnancy-associated myocardial infarction, and less likely Takotsubo syndrome or a myocarditis. So we did a fetal evaluation to basically evaluate the status and prognosis of the fetus. So our evaluation revealed a 1.4 kilogram baby that plotted P3 to P10 for the gestation with a normal amniotic fluid index and a normal screening umbilical artery Doppler. Corticosteroids for fetal lung maturity was omitted in the acute phase due to the maternal condition, and magnesium sulfate was on board for fetal neuroprotection as we did anticipate an imminent delivery. We did, however, omit CTG monitoring for the fetus until we had maternal stabilization. So basically, what do we do now? We have a patient that we clearly suspect has a peripartum cardiomyopathy with or without overlapping preeclampsia. We have our clinical examination that reveals a cardiomyopathy with pulmonary edema. We have non-specific ECG changes and a chest X-ray that clearly shows acute pulmonary edema. An urgent bedside echo was also ordered. But what should we do in the interim? Basically, your aim is number one, to stabilize and deliver the patient. And always remain calm, as a hypoxic patient does not need a hypoxic doctor. It's important to, number one, always follow your basic ACLS resuscitative principles, as well as a multidisciplinary team planning of the labor, the delivery, as well as the postpartum care, using your obstetricians, your critical care team, anesthetics, as well as neonatology. So basically, what do we need to do? We need to reduce the preload by either putting her in the semi-fowler's position and giving her IV diuretics. So we used a IV stat dose of furosemide at 80 milligrams, but you can even go up to 120 milligrams IV stat, as well as IV morphine 2 milligrams. The second thing we need to do is to reduce the afterload. And what can we use? A vasodilator. So you can either use hydralazine or IV nitrates, for example, Tridal. So we opted to use hydralazine in our patient, and we started on an infusion to keep the blood pressures less than 150 systolic and 90 diastolic. Other thing you need to do is have hemodynamic support, either with vasopressors or inotropes, and the choice would either be dobutamine, low-dose adrenaline, or noradrenaline. We must never forget about anticoagulation. So depending on when you are planning to deliver and the stability of your patient, you can either use IV heparin, or if you have some time, you can use low molecular weight heparin such as Clexane, or mechanical thromboprophylaxis in the form of cough pumps. The last thing we need to do is to optimize the oxygenation, and this is done with respiratory support using non-invasive ventilation. As we know, this does reduce your mortality and needs for intubation. So our patient was escalated to non-invasive ventilation, spontaneous timed, using a PEEP of 5 and a pressure support of 5, and we increased our FiO2 to 60%. We did involve anesthesia because, number one, we need a delivery plan. We need to work out the safest mode of delivery. We need to determine a safe window of when we can deliver our patient, as well as the safest anesthetic choice. Then you need to decide, where should your patient go? Can she be in an obstetric high care, or does she need to be in an intensive care unit? So our patient was transferred to our obstetric critical care unit. Her admission SOFA score was 5, which put her at a mortality risk of at least 20%, with a quick SOFA score of 1 and a patchy score of 10. So we chose to put our patient on non-invasive ventilation, spontaneous timed. As you can see, she's maintaining good tidal volumes on very low pressure support and PEEP, and we have a marked improvement in her respiratory rate. So we have a repeat blood gas that we did in our critical care unit, but look at our partial pressure, our oxygen partial pressure. This patient is still hypoxic on a FiO2 of 40% with a PO2 of 14.6 kilopascals. And as you can see, the red flag, the PCO2 is rising. She is compensating with the respiratory alkalosis, meaning that she is breathing fast and your patient is getting tired. Her PF ratio was 272. So I have a better quality X-ray for you. You can see, now you can clearly see the bat wing appearance with the upper lobe diversion, Peri-B lines, and cardiomegaly. So we ordered an urgent bedside echo by a friendly cardiologist. You can see basically what we want to do is we want to confirm our diagnosis of a cardiomyopathy. We want to assess for any concomitant or pre-existing cardiac diseases, and we want to exclude any complications of a cardiomyopathy, for example, a thrombus in the left ventricle, as well as to aid to look at our prognosis of our patient. So as you can see over here, the left ventricular diastolic diameter is 6 centimeters. The patient has a dilated left ventricle with a markedly impaired left ventricular systolic dysfunction of 30%. There is no specific regional wall motion artifacts, and there's a dilated left atrium with mild mitral regurg. So basically what I'm showing you now is a parasternal long axis view showing impaired contractility. And then we have a few videos for you here. So you have a parasternal short axis view as well as your apical 4-chamber view showing your dilated left atrium, dilated left ventricle, and you can clearly see that the contractility is impaired. So over the next 12 hours, our aim was basically for oxygenation and stabilization of our patient. We did insert an invasive A-line for continuous blood pressure monitoring, as well as a central venous catheter in anticipation of us needing inotropic support. We had good blood pressure controls using our IV vasodilator. We did opt to continue the magnesium sulfate infusion as we were not sure if we had an overlap of preeclampsia. We continued our respiratory support in the form of intermittent 4-hourly non-invasive ventilation. She still required minimal pressure support and minimal PEEPs, and we continued our maintenance IV diuresis using furosemide. We did not require any inotropic support at this point, and our biochemistry remained normal. Her SOFA score improved to 3 after 24 hours. A bedside focus revealed interstitial lung edema with a normal VTI. The echo I mentioned previously, and we opted at this point for mechanical thromboprophylaxis in the form of half pumps. So the next step, now that we have achieved stabilization, is to get a delivery plan. And this has to be a multidisciplinary team approach with your cardiologist, your anesthetist, neonatology, as well as your maternal medicine team. So we did choose inotropic support if needed, and our choices was either dobutamine or noradrenaline. we would continue our non-invasive ventilation and IV diuresis, and we would deliver as soon as we have a safe window to do. We opted for a cesarean section delivery with a graded epidural, and we did opt to omit corticosteroids for fetal lung maturity due to the high risk of maternal decompensation, as the risk outweighed the benefit at this point, and neonatology would provide supportive care and postnatal surfactant if needed. The patient was then taken for an emergency elective cesarean section as well as a bilateral tubal ligation. She had a cardiostable anesthetic, which was performed under graded epidural, and this was done to prevent abrupt pressure and volume changes. The graded epidural was done under the cover of multi-drug inotropic support using a combination of a low-dose dobutamine infusion, phenylephrine, as well as adrenaline. So if you have a sick patient like this, number one, you need to have a senior anesthetist as well as a senior surgeon, and you need to make a plan if things goes AWOL. So you will need to have a postpartum hemorrhage plan, number one, and you need to choose the best, most safest uterotonic for your patient. Our choice was a oxytocin using a low dose oxytocin infusion. We did have a uterine balloon tamponade available if needed, as well as a thromboelastography, which was available in our unit with directed blood product administration, and our hysterectomy tray was available in theatre. Thankfully, we delivered a beautiful baby girl, a 1.2 kilogram girl with good APGARs, and there was no postpartum hemorrhage. Immediately post-operatively, the patient was taken back to our obstetric critical care unit, and we continued our non-invasive ventilation. We continued our magnesium sulfate infusion, as well as a low-dose oxytocin infusion. In our unit, we used 10 international units in 200 ml normal saline at 10 ml an hour. We opted to use our epidural for analgesia, mechanical cough pumps, as well as an IV vasodilator for acute severe hypertension, and we continued the multi-drug inotropic support, but it was weaned safely. We then started to introduce our chronic treatment, and we started on a very low dose of an ACE inhibitor, and the choice was enalapril. On day 2 post-op is when we achieved optimal clinical stabilization. We removed our epidural, and then we started prophylactic enoxaparin 12 hours later. And once we achieved euvolemia, we started on a non-selective beat blocker using carvedilol and slowly up-titrated it. We stopped our magnesium sulfate infusion 24 hours post-delivery, and we switched our IV furosemide to oral. She was successfully weaned to room air and given a PEEP bottle. Her invasive monitors were removed, and the baby was doing very well in the neonatal unit. We opted to start the patient on bromocriptine 2.5 milligrams BD. So basically, the patient was counseled on the benefit and the risks of bromocriptine, as well as the evidence of improved mortality with bromocriptine, as Polly mentioned, as well as the high metabolic demands of lactation and breastfeeding, especially in a patient with acute heart failure. This was a joint decision that was made with the patient. We did motivate for formula feeds, and we opted to continue bromocriptine for a duration of 8 weeks. Due to the high risk of venous and peripheral arterial embolism, prophylactic enoxaparin was continued for the duration of the bromocriptine administration. The patient was discharged from our critical care unit to the postnatal ward on day 3. She was discharged on an oral anti-failure treatment as well as the prophylactic enoxaparin and bromocriptine with a date to follow up at cardiology in 6 weeks. The baby was doing very well on discharge. We did emphasize the need to the patient that she must remain on a combined drug regime until we have complete myocardial recovery, and then for at least 12 to 24 hours after full recovery of a left ventricular function, and then only to slowly taper the drugs. But we do know that we might need lifelong therapy in this case. This is just a picture of our obstetric critical care unit at Tygerberg Hospital that is led by Prof. Langenegger and Dr. Ashley Moodley. Thank you.
Thank you. Thanks, Taslim. That was excellent, taking us through that case and how we should practically approach and manage these patients. I must say that you ladies have really outdone yourselves tonight. Brilliant presentations by the both of you. I'm now I've already introduced our star cardiologist, who's actually going to help us along with some of these questions that have come through. We're actually not going to share your presentation for now, so don't worry, Taslim. I think people have already sent through so many questions that we'll have to set up our own date to discuss our issues with CEO. So I think we're going to dive right into the questions for now. I will start off with the question and answer, and I think there may be some others on the chat that we can get to. So please feel free just to give your opinion or comment. So our first question comes from Willem, and Willem wants to know about how crucial or necessary is it to do a pro-BNP in a patient who you suspect peripartum cardiomyopathy, and will it change your management if it is not done, especially knowing that we are working, or most of us are working in resource-constrained settings? Yeah. CEO?
I think in my view, I'll perhaps explain the rationale of using pro-BNP, ECG, and a chest X-ray. I think the problem you face with a pregnant woman is that heart failure is difficult to diagnose. That's the big problem you face. And you need tests that are sensitive when you are uncertain, that you can use to rule out heart failure and use chase something else. So I would say a normal ECG, a low pro-BNP, would certainly make the diagnosis of heart failure very unlikely, and that you must start barking up another tree. So I would use it in that fashion. I wouldn't really do it routinely. I mean, if you're happy that the patient's got heart failure, the patient's got heart failure. But in a situation where you are uncertain, a pro-BNP and an ECG is very useful to sort of rule out heart failure.
Thanks. Polly, did you want to say something?
Yeah, I actually looked at the price of pro-BNP just out of interest today, because we're obviously concerned with cost reduction everywhere in the state practice, and it's actually 3,000 Rand per test. And so I think, we really need to decide if that test is going to be the bang for our buck that we want. And so I think going back to basics and really focusing on signs and symptoms, and using maybe some of our adjunctive measures first, and then reverting to BNP should be the way that we go.
Yeah, I think I would agree with that completely, and the sentiment that it's definitely in the patient where we are not quite certain about what we're dealing with. So I think really we need to be very cognizant and be wary about which test to use when, and especially keep it for when it's most indicated. So a fairly straightforward one, a CEO, I think this one maybe you can answer, is a gallop rhythm always present in peripartum cardiomyopathy?
I think a gallop rhythm can also be common in pregnancy, normal pregnancy, and that's the problem. And again, it boils down to the fact that the usual clinical examination we use in pregnancy has got a lot of confounders. It's because we're dealing with enough normal physiology, and all of these clinical signs are actually verified in people with normal physiology. So I would say I wouldn't really, if there's an absence or presence of a gallop, bet my house on it. I would rather use the whole clinical picture. Again, if I am uncertain, use things like chest X-ray, ECG. If I remain probably use BNP to sort of help my diet.
Yeah, we kind of expected the bromocryptine questions to come in. So obviously, I think people have been very wary, and bromocriptine has been creeping in slowly for a while. And I feel maybe that we are, as obstetricians, are probably kind of more eager when it comes to bromocriptine in the sick patient. And others are obviously on the side of breastfeeding, whereas we say this patient is not a candidate to breastfeed either way. So, where are we going with this? So in the line about what are your thoughts, CEO, about bromocriptine? And then somebody asks, when should it be started, at the beginning, or if there's no response, or response to standard anti-failure treatment?
I think there's very good evidence. Bromocriptine works. Of course, it is limited because unfortunately, the main study is that study by Dr. Sliwa. I think it was about 20 patients, more or less. So it's a very small sample. It was a proof of concept study. And the German guys didn't really find joy with their ethics committee. So it made it very difficult to sort of, in one single randomized controlled trial, to compare bromocriptine versus non-bromocriptine. But I do think there's reasonable evidence that it works. The problem with bromocriptine is that, unfortunately, breastfeeding, you suppress breastfeeding. In an environment where breastfeeding is important, you face a challenge. The second problem is that it's not entirely a benign problem. It increases your risk of thrombosis as a drug. So you must keep also in mind that when you use bromocriptine, you put patient at this risk, and hence we sort of use anticoagulation with bromocriptine. So I would say choose when to use bromocriptine. Clearly, in severe patients, bromocriptine is worthwhile. In the patients who don't have severe peripartum cardiomyopathy, there a little bit of judgment needs to be applied because the therapy we have for heart failure is very good. I think one. The second thing is that some people will use bromocriptine for a short duration, about a week, and I think that's probably also reasonable. And then you stop it. But some people will also choose not to use it. So I think with severe peripartum cardiomyopathy, I certainly would support it. With sort of non-severe, I would sort of use judgment. I'll use judgment.
Thanks, Theo. So our hosts, Royal House, have very kindly agreed to give us a little extra time because we can see that the questions are really coming in. So I think we are going to take full advantage of that extra time. Maybe I can start with the ladies here. There's been a couple of questions coming through regarding corticosteroids in a patient with cardiac failure or pulmonary edema. What are the issues around it?
So I think in such patients, you need to look at the benefit and risk of giving corticosteroids. So we know that steroids itself can cause fluid retention because it increases your hydrostatic pressure in your alveoli. So if you have a patient in pulmonary edema, a patient at risk of pulmonary edema with severe mortality, that will have severe mortality or morbidity with pulmonary edema, then you should ideally omit it, but with a discussion with the patient and a discussion with your neonatology team.
Good. I think that's fine. I think we agree with that completely. How about somebody who's mentioned about cardiac transplantation? How often is this available to these sort of patients with peripartum cardiomyopathy? Any experiences?
I actually looked at some of the registry studies because we obviously haven't had experience of a patient having a cardiac transplant in our setting. And even in registry studies, the rate of cardiac transplantation is quite low because many patients do actually improve over a 6-month period. And even though they might not have full recovery of their left ventricular ejection fraction, they do improve to a point where they can be adequately managed with oral anti-failure treatment. So even though in that patient who has fulminant cardiac failure that's not responding, an emergency cardiac transplant is, an option technically for treatment, maybe not in our setting. I think overall the rates of transplant are quite low.
Just to add on what Pauli said, in the ESC guidelines, they actually mentioned that you should hold off on cardiac transplantation until your patient is on optimal maximum doses of oral antifailure treatment, as these patients actually do much worse with cardiac transplantations because they have a higher risk of rejection in these patients.
Good. Thank you very much. Sia, yes, you want to say something?
I was going to say I agree completely. This is a condition which is reversible. So give your patient time. And I think my understanding is the same as Taslim. They tend to do worse with higher chances of rejection. So as far as possible, give them a chance. Give them a chance. But yeah.
I'm probably going to use two questions at a go now. One has to do with, is there a role for dobutamine in the patient without a preserved diastolic blood pressure? And the second question is around, should you still use IV morphine in a patient with pulmonary edema, given the circular from the Department of Health that showed higher mortality in those who were given morphine? Maybe perhaps Pauli, do you want to start? Yeah.
Yeah, I'm going to leave the dobutamine question to Seal, but I can address the morphine issue. So there's been a systematic review looking at the use of IV morphine in patients who present with pulmonary edema and acute decompensated cardiac failure. And essentially what they found is that the data is really not robust. There are only about 4 studies assessing the use of morphine. And in the largest of those studies, patients who used morphine had an increased rate of mortality, had an increased rate of requiring longer periods of mechanical support. And so I think that's sort of where the circular from the DOH comes from. And I think that morphine has its place in other realms of obstetrics, but I think in the management of pulmonary edema in acute decompensated cardiac failure, it's probably not the drug we should be using. We should be focusing on diuretics and other anti-failure drugs. Over to you, Seal.
I agree 100% with Pauli.
I just like to ask from the speaker, or I'll interpret the way I hear what you're asking, because you ask in a patient without preserved diastolic blood pressure. And I probably suspect that you're concerned here about the vasodilation properties of dobutamine. So I would really say in a patient with cardiogenic shock, you are in a very tight corner. And clearly all of these inotropic drugs, dobutamine included, carry an increased risk of causing tachyarrhythmias and sort of worse outcomes, basically. But in a patient who is in cardiogenic shock, you probably must use dobutamine. You don't really have much options, and you're quickly going to need to escalate to mechanical support devices if you're not winning. And if you're not winning, you probably need to go the transplant route. It's that sort of bad situation, because cardiac failure from cardiac muscle disease is a very bad problem. We don't have a lot of things we can use to help those patients. So dobutamine is still used. And if you're not winning with dobutamine, you quickly must accelerate to noradrenaline. And if you have levosimendan, you can probably start to use those as well. But the evidence for what works in a patient with cardiogenic shock, muscle problem is very limited, and you sort of have to use what you have.
Thanks, Sia. That makes a lot of sense. Maybe we'll take the last 2 questions before we close for tonight. So the one question was how or when should you actually repeat your echo after having commenced anti-failure treatment? Should you repeat the echo? Do you look for clinical improvement, or should you be looking at the echo?
I think you probably mean a patient that is now already delivered and is being followed up, and you're looking for recovery. My feeling is that you probably need to repeat the echo between 3 and 6 months. I'll probably go for 6 months, because then we know that this is the patient we've expected them at this time to have recovered. Before this, you will anyway have to repeat it at 6 months. So I would sort of wait, treat the patient clinically. Of course, earlier, if your patient deteriorates or something else happens and you're wondering whether you've got a new problem that has developed in your patient, but the run-of-the-mill patient who's just delivered, I'd follow them up 6 weeks clinically, see whether they've improved, see whether their diuretic doses can be reduced, see whether or not I can optimize their sort of anti-failure therapy or the awesome foursome, and try to get them on maximal doses of treatment. And then further investigations like an echo, I would consider that at a 6-month follow-up to see whether which patients have recovered and which patients will need sort of to be looked more closely at.
I think myopathy in patients with chronic hypertension, is there access to the S-split PLGF rate? At the moment in South Africa. And it still just completely relies on our clinical acumen and investigations, and sometimes a thumb suck to decide who has got chronic hypertension, who has got dysfunction or decompensation from hypertension versus having some other chronic disease. So yes, we would dearly love to have S-split PLGF in our setting. Ladies, anything to add to that?
Yeah, I think that question also asks whether there's an increased risk of peripartum cardiomyopathy in patients with chronic hypertension. And the answer is yes, because patients who have underlying cardiovascular risk factors are at increased risk of PPCMO. And so, we always stress optimal blood pressure control during pregnancy, but this is another motivation, not just preeclampsia. This is another motivation for us to really focus on good blood pressure control. And maybe controversially, we should ask, does the initiation of aspirin decrease the incidence of peripartum cardiomyopathy?
Yeah, I think that's an interesting question. So I'd like to take this opportunity to thank our audience. Amazing turnout. Thank you all very much for joining us tonight. Remember, we have Soomsa, which is the Society of Obstetric Medicine of South Africa, has a lot to offer. And the rate per year is extremely cheap to join and to actually take advantage of all that is to be offered. And in order for us to bring you great webinars like this in the future, please take the time to join the society, and you can have access to a whole host of resources as well. I'd also like to thank our panel. The content was excellent tonight. Thank you, CEO, for also taking time and coming to share your knowledge with us. We appreciate it very much. I do see that our president, Dr. Willem Lisa Marie, is on the call as well. I'm not sure, Lisa, do you have something to say before we say goodbye for tonight?
Thanks, Sam. No, just well done, and thank you to our speakers. You guys did a really good job. I'll put my camera on. Anyway, hi everyone, and well done. I'm really proud of you girls. Thanks a lot, and thanks for the good discussion. Yeah, thanks.
Okay, great. Thank you, everybody. Goodbye. Have a great night.